All right, welcome back everyone to the afternoon session. We're privileged to have Associate Professor Desmond from the University of Pennsylvania, and he's going to be talking about technical details of online circuit engagement of TMS in the scanner, using TMS in the scanner. Take it away. Thanks.
All right, so thanks for organizers and thanks for attendees. No disclosures. As we heard earlier, we could do individualized connectivity. We can have a neuronavigation camera that shows where you want to stimulate, and so it opens up a lot of possibilities for deciding how we're going to target TMS. And I think there's clinical evidence on one side, right? And then there's slick brain imaging kind of techniques on the other side. And what I hope to do is try to pull them together a lot more. And what I do is fairly simple with respect to capturing a good signal. What we do is more like a mapping technique with single pulses. So it's kind of like getting a motor evoked potential in your hand or your finger twitch. So we're hoping to show that distributed circuits are engaged in response to a TMS pulse. And we also at the same time have our own version of fMRI guided treatment for depression and PTSD. And so we really want to kind of substantiate those and make them work better. Let me tell you more about that as a justification for what we do with TMS fMRI, and then I'll share some tips on TMS fMRI, a little bit of info about how it's kind of set up and what some of the pitfalls are of choosing targets and getting good imaging data. So on the clinical side first, right, to show that fMRI-guided TMS is actually clinically useful, I think our assumption is that yes, it is, but as some other folks mentioned, it's important to have the right target. And when I say the right target, that is something that justifies doing the image guidance. It doesn't mean that I have found the ultimate best target for treating a disorder, but having this comparison with a scalp target, which is obviously much quicker and easier to do. Where's my timer thingy? Is it somewhere? How much time do I have? It's kind of.
You have 3 minutes in total, and you have this is 2 minutes so far.
Okay, thank you. I can see the countdown of when the slides started, but that's good. All right, so in order to justify the hassle and the expense of image-guided targeting, we have to show in head-to-head comparisons that the way they do it in the clinic with something that's a lot less personalized is not as effective. So that's an important, I think, avenue that a number of us are working towards. One of the big challenges is for brain imaging is that sometimes, just by chance, you do a scalp target and you hit a pretty good target that you would have come close to with image guidance. And so this is showing the distribution in standard space of the scalp target in blue and the fMRI target in red, and you can see they're overlapping. So just by chance, sometimes you're going to hit a pretty good target with a scalp target for a patient, and that's going to make it even harder for us to show a difference between scalp target and fMRI target. But we did that crazy thing anyway. We did this clinical trial in depression and PTSD. We found that immediately post-treatment, the depression improvement was significantly better than scalp target. The PTSD symptom reduction took a little bit more time to show the discrimination. The PTSD symptoms continue to improve across 6 months post-treatment, whereas the scalp target drifted in the negative direction, so that we ended up at 6 months with a 70% improvement in depression, pretty similar across PTSD subscales. And the scalp target was more like in the 44% improvement. So that level of improvement stands up to some of the best stuff that's out there that's been published, especially if you look at the 6-month mark. Not the immediate treatment, but we want the patients to endure with their clinical benefits, which is especially difficult to do. So no retreatment with TMS, one single trial, and these are the outcomes. That's really cool, except that we were aiming at the subgenual connectivity target, and the clinical evidence on its own is not enough to say that we actually engage that circuit, that when you fire TMS to that location in cortex, obviously we're not stimulating subgenual directly, and we were aiming to target it, just like the same protocol and many others. It doesn't mean that we actually got the target. And even if we did get the target, what's the evidence that we modulated the target? And if either of those things are true, what's the evidence that that's actually clinically useful and tells you something clinically about how the patient's improved? And so for me, that's the difference between aiming for something and validating that you actually have the brain effect that you think you did. Just because you do fMRI-guided targeting doesn't mean you know anything about where TMS propagates in that patient or how it modulated a circuit. So that's what I'm kind of arguing for. One tool that we can use to potentially establish that relationship between what TMS does and the clinical effects is the concurrent or interleaved TMS fMRI. What's really nice in our particular application of fMRI is that the bold response is slow, right? So we can ping between acquisitions, between readouts, between the TRs. We can put a little gap in there between them. We can ping the circuit without corrupting the image at all, turn on the recording, and capture the evoked response in the brain. It's very clean, very simple. It's a ping of the circuit. It's mapping the circuit with single pulses. It's not the modulation part yet, right? So just doing the mapping, you say, oh, that's cool that other people are doing theta burst in the scanner. They're doing 10 hertz and capturing the evoked response, and that's more similar to what we do clinically, so isn't that better? I would say they're just different, right? Doing repetitive TMS with the aim of neuromodulation is different than a basic just ping the circuit, map it, right? Which is what we do with single pulses. We started out doing this a long time ago. This was back in the days when I was working at Stanford with Amit Etkin, and we said, all right, well, you have these resting state networks that look like they're all connected, but that's all a bunch of correlational data. Like, is that really definitive? Can it be useful for especially TMS, where you apply TMS to one spot, right? You don't apply TMS to a whole network at the same time, but what you're hoping for is a distributed brain effect. So what if we just started pinging at the cortex some of the representations of these canonical resting state networks, and we found evidence that you can engage them, these distributed network effects, with these pings of the single pulses to one of the nodes that are accessible to to TMS at the cortex. And we also showed this more causal relationship between task positive and default mode networks, where we ping the task positive, you get an up response in the bold, and you get a down response in the default mode network, showing this antagonism that before you only saw with resting correlations. So showing that there could be a way, if, for example, you really want to turn off the default mode network and you assume through the correlative imaging that there might be a relationship, this is a good kind of basis for predicting that relationship would happen. So since joining the faculty at Penn, we've been trying to stimulate indirectly, again, some of the deep subcortical regions that we think are particularly important for anxiety and depression, like subgenual cingulate and the amygdala. But just because we're aiming to engage those circuits doesn't mean that we did, especially at the individual subject level. So we do these resting correlations, we look for hotspots correlated at the cortical surface, and we just start pinging them to say, hey, does it look like they're actually engaging the intended targets? So again, this is not directly stimulating these subcortical regions, the stimulating circuits, pathways between the cortex and the deeper brain regions that we think are the ones that we want to engage. So this is what you get. You kind of space these TRs with a little ping in between them without corrupting the image, put them in the scanner. You do, in our case, we do 71 trials of this. In terms of methods, there's one paper out there that helps with deciding this, which is Colin Hocko's paper suggesting you need at least 50 pings to get a good, reliable brain-evoked response. So we do 71, so we're over the 50, which is good. You get a whole brain readout for the price of that one acquisition. So we played around with resting connectivity guided stimulation. We do our ping in the scanner with TMS fMRI, and we said, hey, everybody's chasing this anti-correlated target. What does it mean if you took a positively correlated target and you ping that? Like, let's see what the evoked response in the subgenual looks like. So, and that's something that we're actually continuing with a bigger clinical trial. And at the same time, we also follow this putative amygdala pathway based on resting connectivity. We found a relationship between the evoked response in the amygdala, which is replication, and the fiber density of a pathway between where we stimulated with ventrolateral prefrontal cortex and the amygdala. And that all sounds good, but we're still talking about here's this clinical evidence, here's this imaging evidence. We really need to start pulling them together. So we developed this protocol where we do this interleave TMS fMRI. We do a round of it. We do a brief intervention over a few days just to test this circuit hypothesis. We think it's enough to move depression, but not as optimally as a full clinical trial. But just to decrease the burden on testing the circuit hypothesis before we run a huge clinical trial, we say, hey, we want to ping the circuit, we want to do enough modulation that we think depression is going to improve, and then we want to ping the circuit again and see if there's any change or if there's any way to predict how well the patients are going to do clinically. So this is our prognostic predictor evidence, which is to say we ping the circuit before the intervention, and it tells you how much depression improvement the patients are going to have. So from the interpretive perspective, I think this is a reasonable way to suggest that the integrity of that pathway that you stimulate with TMS actually tells you something clinically useful. So potentially, that means if you and I have different ways of processing our imaging data, we have different ways of suggesting putative targets for TMS, before we do the actual intervention or treatment, we could ping multiple nodes and say which one of those engages our target better. And that might be the best way to treat the patient. We don't have to wait for the clinical evidence to tell us that it didn't work. We can try engaging the circuit ahead of time and optimizing for the outcome we want, as long as you know what the brain target is that you're really chasing after. Similarly, now this is the pre-post change in the evoked response. So ping the circuit before the intervention, ping it again afterwards, and look at the evoked response change. And we found again an association between the clinical response and now the change in the evoked response in the subgenual cingulate, suggesting this may be mechanistically important, like this pathway between DLPFC and subgenual in the context of depression improvement may actually be mechanistically related and important. And also validating that these pings that we're doing actually tells you something interesting. We don't have, there's no commercially available sham stimulator for the scanner. So in terms of practicality, one thing you can do is you can stimulate multiple active targets, and you get the whole brain readout, right? So you stimulate high subgenual connectivity, you stimulate high amygdala connectivity, you look at nearby evoked responses in the amygdala versus the subgenual cingulate, and you say, hey, is it important the degree to which you engaged the amygdala versus the subgenual cingulate? How does that relate to depression improvement? So that's what all these different lines suggest. So we have this control region, which is an active stimulation target, right? We stimulate both regions, and only the dark blue line, which is the subgenual connectivity, the subgenual evoked response, only that was a predictor of depression improvement and none of the other lines. So that's one way to do a controlled experiment with TMS fMRI. We also showed symptom specificity. So that's another thing that you can do. You can say, okay, I got an evoked response in this region, like subgenual cingulate. Is that depression improves, anxiety improves. Again, black box, we don't know what happened. But with the pings, maybe you can start to unpack some of that. We found that subgenual cingulate change in evoked response was related to a depression improvement, but was not related to anxiety improvement, suggesting that that may be a symptom-specific pathway. Nevertheless, anxiety improved, and you get the whole brain map. So looking over the data, we found that the subgenual cingulate, if you look across the whole brain, you can see there's a hotspot there for the depression improvement. That doesn't mean that subgenual is the only thing that you should care about in terms of improving depression. Obviously, subgenual doesn't do anything on its own, even in response to the cortical stimulation. There are other brain regions that their evoked response change is also associated with depression improvement. And then the other fun thing is that you look at, well, which regions were modulated and associated with anxiety improvement, because we know anxiety improved. And it looks like some nearby regions, but not the same regions. For example, ventromedial prefrontal cortex, just anterior to the subgenual cingulate. So cycling back to this, you have a theory of how to stimulate a network. I have a theory of how to do it. You can stimulate multiple brain regions in the same session with the same patient and try to use that to optimize how you engage the target. Another thing we're playing around with is let's do something a little bit more sophisticated. Let's throw in some machine learning. Let's use some normative data. Let's combine it with the imaging data that we collect from the individual patients. Let's try it in something that we have seen traditionally in TMS studies. You might be able to affect with TMS even in an acute session and say, let's combine those together. So we have this LSTM recurrent neural network decoder that we developed from the baseline session, and then we take it to the TMS fMRI, where we do short rounds of repetitive TMS at different frequencies, and we look at how well the behavioral response changes and how well the decoder is performing. So we use that to decide what's an optimal frequency for that patient, for that target, in terms of that behavioral context, and then we try doing that in neuromodulation sessions across 3 days. And we found that the baseline imaging decoder didn't do a great job of telling us anything about behavior, but eventually, as we kind of fed more and more data into the decoder from the TMS fMRI sessions, the decoder kind of got more and more precise and relevant to the behavioral outcome, where ultimately the decoder's performance from TMS fMRI could tell you how well the participant's going to improve with working memory. So this is guiding also the personalization of the target, using normative data, but also augmenting that with personalized stimulation frequencies. And I will say we did split it across the different frequencies that we tested, and it was not consistently one frequency across all people was the optimal decoder. It really took this extra layer of optimization for personalizing the frequency to get the behavioral response that we wanted. So we're trying that. All right, so preliminary conclusions, fMRI-guided TMS seems to engage at least a couple of these downstream subcortical targets. That seems to work. The engagement of those circuits with these pings it tells you something meaningful about clinical effects. Also, backing up to the first stuff with the clinical evidence, fMRI-guided TMS seems to be more clinically effective than a scalp-guided target. I think that's really important to justify the imaging. And then also we're playing around with this machine learning and figuring out more personalized stimulation frequencies in addition to targets. This is another thing that I'm working on, which is just to put something out into the community and saying, all right, so we've collected a lot of data over the years with a bunch of different projects, and let's instead of saying that we know where the subgenual cingulate is, what we maybe want to optimize is the engagement of the subgenual in response to a TMS pulse. Right? And so if you look at the kind of imaging response to that, to the pings, the definition of where the subgenual cingulate kind of lights up, in our case gives a negative bold response, doesn't follow a sphere or even the free surfer parcellation. It's kind of localized and circumscribed around the subgenual cingulate. And not only the subgenual cingulate, right? We really care about some of those other brain regions that when you do this guided targeting, you get an evoked response in these distributed circuits. So let's throw those out in the world. Let's say make a minimum threshold of the strength of activation and the number of people that have consistent activation in that direction, and publish that in case somebody wants to use that and relate it to a clinical response. Pitfalls. So this is one of the things I was hoping to demonstrate. with BrainSight, but couldn't get my laptop to wake up. But I'll say there's junk in your imaging data that you need to be cautious of. So like edge effects are particularly pronounced. There are reasons for that. There's imperfect segmentation. There's unmodeled head motion that gives you these spin history effects. So right at the tissue boundaries, like where we're trying to stimulate with TMS is particularly prone to these kinds of errors. And so if you look at your imaging data and instead of just blindly saying, oh, I want peak connectivity is what I should do. I don't have to look at it. I'll just get the coordinate for it. I'll slap it into BrainSight and go to town on it. It's too easy to get these artifacts, so you should really look at your own data. You should play with the threshold and say, okay, does it follow a brain contour? Is it kind of hanging out in space in a region that you have less confidence in? Another thing is that within the software, it does its own version of a brain model that has certain regions where you can still see some of the blood vessels, and so you can play along with like the peel depth of that image to look at your fMRI target. So that's something to be cautious about. There I'm demonstrating that. So it's not that particular cluster or blob is not a good one, but looking at your data carefully will tell you whether it looks like that's a spurious target or not. But if you don't look at it and you just assume that the peak is usually not the best place to stimulate in the most valid brain region. Another issue is TMS feels like something. So for those of you who have had TMS, having a flick on your scalp, flick, right? That's a really good way of activating your brain stem, your dorsal cingulate, your insula. They're kind of common regions depending on how painful the things are. The DMN will turn off nicely just to a flick on the head that doesn't actually engage the brain. So one of the strategies we have is to ask participants, how bad did that one sting or hurt or discomfort, and regress that out of the image. So that's what we're doing here. The green blobs are showing you where the regions are that are related to the discomfort sensation, and as you can see, they overlap a lot with the image that doesn't account for those pain readings. I'll also say that asking participants to give you ratings on things is a reasonable way to go, but there's also the somatosensory kind of response, and you can kind of carve out that part of the brain and say, what's the evoked response in somatosensory cortex, and you can kind of regress that out of your image. That's another, I think, reasonable approach. Another issue is that we don't really know at the individual level how far TMS kind of propagates through nearby brain regions, and how close we should be allowed to be with having TMS targets that if you're stimulating multiple brain areas. But I'll think that to the degree that you can, having 1.5 centimeters or so between your brain targets is probably more reasonable than having them overlap with one another. So paying attention to proximity, that limits some of your ability to test things. For example, right now I'm testing that positive versus anti-correlated target. How well does it engage subgenual cingulate? And I have to make decisions about moving off of a target that looks like a pretty good blob because its valence is not consistent. So it depends a little bit on your hypothesis, but if you really want to discriminate the targets for condition A versus condition B, say for example, you don't want them to really lay on top of each other, and if they do, you might have to choose your kind of second best target when they overlap. All right. Another issue is that TMS close to the face, does that feel better or worse than ones that are more posterior? We get it worse, we get it worse. All right, audience participation, everybody agrees that's worse. However, sometimes You're looking at that target and you say, oh, that's such a good target. I really want to stimulate it. That one looks so consistent. That one's really going to do it. The patient just needs to put up with it. I'm going to do it. And so you as a TMS, especially in the clinic, you'll do all kinds of tricks of ramping up the stimulation level, slapping an ice pack on there. People do lidocaine injections sometimes. So you're like, we need the patient to stimulate this, especially in addiction. This is your bread and butter right here, right? So you're like, how can we get the people to tolerate it better? If you have a choice, knowing that that's going to sting pretty badly and some patients are really going to not tolerate it very well. If you have a choice, say multiple connectivity blobs that are homogeneous, look pretty good, close to the scalp surface, and you want to stimulate them, having a backup target is not a bad choice. So for me, like, how much do I believe that this like 0.67 on connectivity versus 0.72 is really meaningful, especially, as was pointed out earlier, there's some drift in time with resting connectivity. I would say those are above my threshold for saying that I think I have a good target, and having a backup target ready in case you need it could pay off for you. Especially in the context of TMS fMRI. So what happens in a TMS fMRI experiment? The participant comes in, they get a 2-hour battery of symptom assessments. They come in for a baseline scan. You've already wasted an enormous amount of time and money getting that person enrolled in your study, and then they come in for the TMS fMRI session, and then all of a sudden they're like, nope, that target's not good. I'm not going to let you stimulate me there. If you don't have a backup target, you throw away all their data. You don't have any TMS fMRI data. You don't enroll them in your clinical study, whatever. So that's problematic. So having a backup target could pay off for you. I highly recommend it. All right, this is just some of the equipment. Most everything we have is a commercial equipment. So having these waveguides and the filters, the panels, like this is what it looks like outside of the MRI room and the adjacent room where you're going to have the actual stimulator live. Right, so it goes through there. These are shielded cables. There's copper Litz wiring in the TMS coil, but the cable that goes from the wall to go inside the bore is super long. And so as a factor of the filtering and the length of the cable, the amount of juice you can deliver to that target is not going to be as high as with your little clinical machine or behavioral machine. As a result, sometimes you run into firing the stimulator at 100% of its output, and it's still not very strong, but the models of safety are built around not filtered and not long cables, and so they don't adjust them for this particular TMS coil, which I think is a shortcoming. As a result, you may be stimulating at a lower intensity than you originally planned with the stimulator turned up at 100%. That's a limitation. It's more the equipment. So there's always, especially when you turn on the stimulator, the capacitor is charged up. You're going to get some leakage of that current through there that has a potential to contaminate your signal. It's all better than it used to be in the olden days, but it's still something that is a limitation of what you can do. The commercially available coil holder I hate. That's the only one that's available for certain purposes. It's fantastic. For example, if you want to lock down one brain region and keep it there for your entire scan session, it's pretty robust, it's pretty solid, it lays in the bed of the scanner, it moves in and out. It has all these articulating joints, and it ratchets down, and it holds pretty nicely, and there's enough flex in it that if it flexes the kind of scalp muscle and it moves it, it'll snap back into place pretty nicely, which is important because you don't want the motion contaminating your fMRI signal. The downside is that it takes a really long time to get it into place and to work it into the places that you want, and I always want to stimulate multiple brain areas, so I'm running in there trying to pull out all the participant, reposition the TMS coil, and so for us, our custom-built solutions have worked a lot better. All right, so that's what it looks like, TMS coil, little holder. We have an independent computer sending triggers for the scan acquisition, volume by volume, and also triggering the TMS box. So that gives you a lot of control over timing. So you have this DB29. Each pin is kind of devoted to a different piece of hardware. Has an independent pin for each piece of hardware that you want to independently trigger. Yeah, that's what it looks like from another view. Also say that verifying that it works is important. So you can plug in, after this breakout box, you can plug in the cable to an oscilloscope and measure the timing and make sure that the triggers are firing properly. On the scanner side, you can do the same thing with the cable, but you can also verify, at least with a Prisma scanner that we have, there's a physio recording that shows the slice-by-slice acquisition triggers, and so we know exactly when the volume is triggered and the time between them. And we found that there's very little slop in our design. There's like a 4 millisecond slop, which I can definitely deal with. Our gaps between the volumes is 400 milliseconds. We hit a single pulse right in the middle of that. We tested it with 200 millisecond gaps, and it works just as well. Anything shorter than that, I'd say verify the signal that you're pulling out. So having some of these old school LTP cables come in handy for this. So that's for precision of the triggering. For controlling through the serial cable, something like the stimulation amplitude, the frequency, things like that you want to control remotely through the box. The serial cable, USB, et cetera. Speed is not the priority, so you can control it through those other types of ports. That's what the setup looks like in terms of what lives where. So you're in the control room, you're sitting there with your computer that's running. We're doing CyclePy right now, but we have another acquisition with MATLAB and PyTorch. We have ePrime traditionally, so the software isn't as critical as your ability to use it and control the precise timing of when the triggers happen. That's what I was talking about, the verification. You get these TR by TR kind of triggers. You have an oscilloscope. A lot of the newer ones can record all of the triggers that come in, so you can kind of save the data and look at to verify not only the timing, but when your cables start to break down and something, there's this little pin that you stick into the TMS box with that little orange circle on it that sends that verifies the heating of the TMS coil and also which TMS coil you have plugged in. And if you bend those pins a little bit, you can sometimes get the information and sometimes not. That recently happened to us. We were so frustrated trying to troubleshoot exactly what the problem is. If you don't have something that's clearly broken, that doesn't function, it occasionally works, it's so difficult to troubleshoot actually what the problem is. So I'm sorry I couldn't get the brain site to work. It would have just been fun, but it's just basically saying the same things that I was saying before about finding a good blob versus something that looks more like noise. So I think you guys got the gist of all that, but if anybody has specific questions, I'll be around.